Lecture will start right now. Thank you for your patience. Okay, good morning. How are you guys doing? Good. I think we're still waiting for a few more, but we'll get going, okay? Because it's about 20 after. So, I know some of you were here yesterday. We did a lecture on the concept of treating edentulous patients. So the concept of all in four, that's what we talked about yesterday. So it was the hands-on and so on. But today is a different topic, okay? We're going to talk about the concept of growth factors, okay? Concentrated growth factors and how we can utilize it in implant dentistry, okay? It's a very, very unique concept for those who are new to it. It's very different than some of the traditional techniques that are out there, such as PRP, okay? I've been to a lot of lectures on this topic, and a lot of lectures that you go and listen, it's based, they talk about theory, too much of the basic science behind it, okay? But not so much, they don't teach much about how to apply it in dentistry, okay? For example, you know, Dr. Chokran, you all know Dr. Chokran, I guess. He's an inventor of PRF. You go to his lecture, he talks about, you know, I mean, he's not a dentist, right? So he doesn't know much about dentistry, but he tells you, how to make the membrane and how it's made, how wonderful it is, but it's lacking in terms of how do I utilize it in dentistry every day? How can I use it in mixing bone? How can I use it in socket grafting? How can I use it in the sinus? How can I use it in deficient ridge? Okay, so what I want to do is I want to cover a bit of the background behind it and the science behind it, what's in it, okay, why it works. But also I do want to tell you how we can apply it in everyday cases that we see in our office. Okay. So the objective is we'll talk about the biology and the clinical application of concentrated growth factors, or CGF. Okay, so I'll talk a lot about CGF, and also we'll learn how to make something called autologous fibrin glue, AFG. Okay, and also obviously we'll talk about how to make CGF membrane. Okay, and also something called sticky or putty bone. All right. In the afternoon, after lunch, we're going to have a hands-on session. So I'll be drawing blood, okay, and we'll spin it in the centrifuge. We'll make the membrane, but also we'll make a sticky bone, which is kind of very, very nice. Okay. We'll talk a lot about socket grafting. Okay. I think this is sort of the basis of foundation. How, if you're not doing a lot of grafting procedures, you should be starting out with socket grafting, right? You're not doing a lot of ridge augmentation from the get-go. So do a socket grafting and then move your way up to different type of more complex procedures. We'll talk about how to manage thin, deficient ridge, cases where there's no bone. Okay? I mean, you need to have bone, correct? If you're going to be placing implant, you need to have bone. And a lot of times, we take a CT, there's concavity there, or this very, very thin ridge, and we don't know how to manage it. Okay? So we'll talk about that. So if this is your patient that comes to your office, and you're ready to place your implant, okay, you've taken a CT, well, it doesn't look too bad, okay, the thickness is sort of borderline, and you stick two implants, and this is what happened. Have you seen this before in your office? It happens to me all the time. And you're sweating, oh, geez, what am I supposed to do here? I've got, most of the exposed threads in the buckle here, and am I going to put a bone, membrane, connective tissue graft, or am I just going to close it up and send the patient home? And what's going to happen to the bone that we place here? Is it going to stay? Is it going to resorb? Am I going to put a titanium membrane, do a block graft? There's a lot of questions behind there, right? And there's a lot of options out there. Okay? And what I want to do today is I want to make it simple for you guys. Really simple. Okay? How about cases like that? You've taken a tooth out and you see a bony fenestration, a hole on the buccal. I see it all the time, especially endodontically treated teeth, right? And how can you manage that here? Okay. So the question that I want to ask you is, which grafting technique is the gold standard? There's so many out there. Okay, there's a block graft. You can do a traditional GBR with a membrane. You can use a tenting screw, titanium reinforced membrane, Gore-Tex membrane, titanium mesh. Okay, or ridge splitting. Which technique works for you? Right. And the other question is, what about the graft material that we're putting in there? There's so many choices, right? There's allograft, there's alloplast. What else is out there? Xenograft, right? Animal bone and human bone. And you go to a lecture and someone says, oh, yeah, you know, you have to use BIOS or xenograft. That's the only thing that works. Okay? Someone will tell you a different story. Okay? So I'll make that easier for you as well too. Okay? So obviously there's so many choices out there. I stopped doing any type of autologous grafting in my office. When I went to Perio in Chicago back in 2000, I graduated in 2006. We're doing a lot of block grafts. Okay, it was just a cool thing to do, right? And back then, you know, a lot of old surgeons were lecturing about block graft and so on, and it was just a cool procedure. You know, going to the back of the ramus or going to the symphysis, take a chunk of bone and putting a screw in there was just cool, you know. But think about that in your practice. If you're doing that on a daily basis, you're not going to get a lot of referrals. Patient's not going to be happy. So after Chicago, you know, I came back to Vancouver because that's where I'm from, and I was working, and I wanted to do block graft. That's how I was trained, right? And what I realized is that patients were not happy. There was a different story than in dental school, right, or perio. You do the procedure, it's too way too invasive, too much complication, a lot of bleeding, postoperative issues, and the issue was that patients were too scared. They would not refer other patients to me. They go back to the referring doctor and say, you know what, Dr. Jennings, you know, he just tortured me, you know, big chunk of bone. I didn't like that either. Okay, so you have to try something different. Now, what about xenograft? Okay, we all know it as a BIOS a lot of time, right? Is that right in the States as well? BIOS was very popular. I'll say early 2000s, even before. Even now, I mean, a lot of clinicians, that's what they use, okay? Now, if you look at the literature, we don't see a lot of articles that talk about xenograft or bovine bone, right? I think the trend is going down, okay? One of the issues with the xenograft that it just stays in there for too long. You place a graft material, let's say, you know, if you're doing a socket grafting, you put it in the socket, you open it up a year later, I guarantee you, most of the particles are still there. Right? Have you seen that before? It's all granular, isn't it? It's not really smooth, real bone. Right? The volume stays there, but it's not the bone that we want to have, especially when we're doing implants. If you want to just preserve the volume, yes, go ahead. It'll stay there forever. I've seen cases where you open it up 10 years later, it's still there. It's very mineralized, okay? What about allograft? This is my choice here. I like to use human bone. Okay, and I think this is a trend that that's going right now for most clinicians. And if you go to the bigger implant meetings, for example, like AO, AAP meetings, this is what they'll talk about the most. Because in reality, it's human bone, right? It works. Same characteristics, okay? What about synthetic? Synthetic bone is available, it's out there. Again, the issue with that is that it just takes too long to resorb. A lot of times it does not resorb at all. You put it in, you open it out, let's say a year later, it's all granular, there's a lot of particles. It's not intact, smooth bone. Meaning that the turning over the graft material has not happened. Right? So it's not really my choice. If I want to have it on an implant surface, I would not want to put a synthetic material. The only time I put something in the ridge is that if I want to maintain the volume. Because that thing's not going to resorb, it's going to stay there. But it's not real bone though. Okay, that's the issue.
Regarding the allograft, the other discussion is, cortical versus cancellous, percentage of one or the other.
Mm-hmm.
What about that?
Oh, here with the allograft? Right. So allograft, it comes in different forms, right? You can get it in cortical, cancellous, or mixed. Yeah. My preference, I like to use cortical. I find that cancellous is a little bit too mushy, soft. Yeah, so I like these cortical. I mean, you can buy them in blend. I don't know what they come in, 37%,
70, 30.
something like that. It depends. I mean, for example, for socket grafting, you can put cortical, cancel, doesn't matter. It'll just heal. It's a contained defect, right? So it's going to heal. But if I'm doing a lateral ridge augmentation to augment the buccal area, I'll definitely go with cortical. I find that cancel is a little bit too mushy and soft. Yeah, that's my experience.
It turns over quicker, so you lose the volume.
Maybe. Yeah. We'll talk about allograft a little bit more later. We'll talk about particle size as well. Okay, what works the best when we're doing the sticky or the putty bone.
Also,
Yes.
on that same topic, do you prefer mineralized, demineralized?
Oh yes. Going back again. So the topic of allograft. So that you can get them in mineralized or demineralized form, right? So what's the difference? You can get them in FDVA, DBA, right? Yeah. What's the difference? What do the ref tell you?
Supposedly as BNPs, you have some level of BNP.
With the demineralized?
Right.
Yeah.
That's the.
I'll talk about that in a bit later, but the amount of BNP in that graft material that we have, so BNP is a bone morphogenic protein, like growth factors, right? We need it. We need it to allow to have better healing, quicker healing, right? So they say there is some BNP in that bone, right? Correct? In that little dry bone that's been sterilized, irradiated, chemically, everything's killed there. Do you think how much growth factor is in there? Nothing. In the amount of picograms. Picograms is like, I mean, you can measure it, right? But it doesn't do anything in terms of healing.
It's not clinically significant.
Exactly, it's not clinically significant. It's statistically significant, depending how you look at it, but it's not clinically, doesn't make any difference. So, to answer your question, whether you want to get it demineralized, mineralized, I don't care, it's up to you.
Also, there's the option for freeze-dried or not. Are there any thoughts on that? Freeze-dried?
Well, you have to get it freeze-dried.
Yeah.
Yeah, it has to be, otherwise, how are you going to kill everything, right? So, anyways. So let me move on here. So, what are some of the ways of increasing ridge thickness? So you can do block graft if you like. Okay. Again, I don't do block graft. Okay, I stopped doing that. What I use is particulate bone, particulate allograft. Right. So you have the bone, and how do you use it? Because obviously you got to put something on top of it. Correct. You cannot just put bone and close it up with a flap. You have to put some sort of barrier. Right. So there's different types of options out there. There's Gore-Tex membrane, titanium mesh. You can get some collagen resorbable membrane. I was talking to the other gentleman there. There's an amniotic membrane too, right?
Yeah.
Coming from, is it from placenta?
Placenta, yeah.
Yeah, of human being, right?
Yeah, it has all the stem cells in it and everything. Feels very good.
I don't know if there's a lot of stem cells, but
That's what they say.
yeah. So there's different types of membranes out there, okay? So basically, there's two categories. One's resorbable and the other is non-resorbable, okay? I don't use any type of mesh, titanium, or Gore-Tex membrane because there's too much complication. If it gets exposed, it smells, it gets infected. I like everything to be simple. I mean, having practiced for about 10 years now, I realized that I want to go home without any stress. Okay, I have a kid now, I'm married, so I just want stress-free practice. But at the same time, I want to make sure that we get the same predictable result, right? So I don't use that. I only use resorbable collagen membrane. That's all I use. There's also, a technique of something called ridge splitting and expansion. I think we've got some cases on that, okay, which works very well. So if you're doing a block graft, this is typically what you do. You have to decorticate. Okay, with any grafting procedure, okay, in the mandible, okay, you have to decorticate, right? So I just use a surgical high speed, okay, small carbide burr, and I just go through the cortex, punch it, boom, it'll drop. And what happens, it'll create some bleeding. I don't do that as much in the maxilla because the bone is much porous and softer, but in the mandible, because it's so dry, the cortex is so thick, you have to decorticate before you place any graft. Okay? So let's say, if you don't put anything in there, the graft most likely doesn't survive. You need some blood actually. You need some blood for the graft to survive. The basic principle. Same thing with soft tissue. Okay? There has to be some bleeding. Okay? So we punch some holes, and then you go to the chin. Okay? and take out a couple chunks of bone. That's a quite invasive procedure. What happens with this area when you do block graft? Does the bone grow back here? It doesn't.
There's a lot of morbidity, I think, in this.
Oh yeah, there's a lot of morbidity. What happens to the vitality of some of the incisors? And how about closing this up? You have to do it in two stages. One, you close the mentalis muscle, and then the mucosa on top of it. You cannot suture just in once because the muscle's going to be dripping down, right? Unless you want the patient to have droopy lips. So this is it's too much, especially for most of you who are general practitioners. This is not something you want to be doing in your office. And the oral surgeons love doing block graft. That's what in Vancouver they still take patients to the hospital to take hip grafts. I'm like, really? I mean, you just need a tiny bit of bone for 2 teeth, and you have to do hip grafts? You got to be kidding me. And what about the morbidity when they go through hip grafts? Right? I mean, it's quite invasive. And the bone does not grow back here when you take it from the hip. Okay? So these are some of the other techniques that are being lectured and talked about when you go to the meetings. This is a titanium mesh, okay? So you place the graft and close it up. Or this is titanium reinforced Gore-Tex membrane. Gore-Tex, okay? It's a good barrier, okay? And you have to, so a lot of times you have to fixate them, put some pins, and it's a lot of work. You have to bend the membrane. But if you don't do it properly, what happens? This is about a week later, it gets exposed. When that membrane gets exposed, it's perfect for the plaque and bacteria to get in there. Okay? Do you want a patient to come back a week later like that? Not only doesn't look, pretty, but the patient will be complaining. Dr. Jang is smelling really bad, it's getting yellow. I'm getting some pus out of it. And you're concerned. Am I going to take this out? Well, how do you manage it? It's not easy, I'll tell you, but eventually you have to take it out. And that's another surgery. It doesn't just slide out because you got those 2 pins in there. So you have to raise a flap. What about the bone here? Do you think that bone is going to stay there? When the membrane gets exposed, a lot of bone just shrinks, resorbs. Okay? So I don't do that anymore, that technique. It's too complicated. So my question is, are there any predictable ways of augmenting a deficient ridge? Okay? For me, it has to be very easy, straightforward. So I want something that can handle very easily. Okay? I want something that has ability to maintain the shape. That's the key. When you're doing bone grafting procedure, it has to maintain the shape, right? If the patient's pressing on the graft material all the time, that pressure is going to cause necrosis of the bone, and the graft material doesn't stay. So keep that in mind. And also, I want it to turn over in 4 to 6 months. So I know I put some particular bone in there. When I open it up, 6 months later, I want to see real human bone. Don't want to see any particular residue in there. Okay, which can happen we talked about that with a bovine and synthetic bone. Okay, so in implant, if you're doing implant, you want to have real bone when you open it up. Okay. So a lot of clinicians say, okay, I like to mix my bone with saline, antibiotics, Emdogain, whiskey, gin. No one knows what they're doing, They're like, oh yeah, I like to put a little bit of tetracycline in there. I don't know, I just put a bit of something in there, just mix it, because I heard in the lecture. I mean, they're okay, because you need to hydrate the bone, number one, right? For me, I don't use any of these here, except for saline solution. Okay? If you want to hydrate the bone, just by itself, I'll just put in saline solution, hydrate it for 10, 15, 20 minutes, and place it. You don't want to place it dry, okay? But antibiotics, I mean, you don't need to, because I do systemic antibiotics, right, orally. Emdogain, if you have extra, cash in your drawer, just go ahead. But this is quite expensive, right? Calcium sulfate, which is a plaster of Paris. It's okay, it kind of helps with kind of make the bone a little bit more stable, I guess. But I don't use that anymore. I've also heard that, some dentists like to just scoop a bit of blood from underneath the flap and put it in the bone. You could do that, but it's difficult. You don't get a lot of blood. Okay. So this is what I see all the time in my office. Grafting. I would do a lot of gum grafting. Okay. And when I'm doing grafting procedures, patients complain. right? Especially if you go to the roof of the mouth. You're taking a big chunk of connective tissue for root coverage and so on. Patients complain, okay? And I want them to have a good experience because I know how uncomfortable it is, okay? So cases like that, they're very easy to treat, a lot of recession, frenum. So I do cut the palate sometimes, right? But I'm leaning more towards allograft material. So this is the skin of human being, okay? And you can use that, and hydrate it in growth factor, okay? Which allows the area to heal quicker. And I use that instead of the patient's connective tissue graft. So we close it up. Okay, a lot of times I don't have to close it completely because we've got the growth factor in there. And that's what it looks like. So without going to the roof of the mouth. I know it looks quite fake, but you can get a nice, predictable result. Okay? So you can use growth factors for soft tissue healing. Okay, same thing here. Okay. Also, we do a lot of all-on-4s in our office too. Okay. So this is a patient that has a cleft palate right here, and everything was failing, a lot of decay and so on, and he ended up going with partial, and he couldn't handle it anymore. So he asked me to do something fixed. So we ended up doing an all-on-4 for this gentleman. Okay, there. The implants, they look like they're touching, but they're overlapped actually. One is more buccal than the other one, so worked out really good here. Okay, 4 implants, 1, 2, 3, 4. Now let's talk about growth factors. What's growth factor? Okay, we all have it in our body, correct? And more specifically, growth factors the concept has been around for a long time. Okay, it started off with the concept of PRP. Okay, I know a lot of clinicians still are doing PRP. Okay, even oral surgeons and periodontists in Canada, I know some of them in the States, they still mention and talk about PRP, which is an ancient technique, it's old. We should not be talking about PRP. If you're a referring doctor, whoever, if you go to lecture, if someone's talking about PRP, they need to be updated on the latest technique. Because PRP, it's too, there's too many steps, right? Too many steps, you guys, take the blood out, mix it up with some of the, some agents. It does not work very well, okay? But in medicine, they're still using it. Okay? So a lot of sports athletes, okay, they need to perform right away. So they get injured, right? Let's say if they have a shoulder injury and they need to get back in there real quick to perform. So these two guys are getting them actually. So they have the blood drawn, right? Spin it, okay? They have the growth factor and they have it injected to the areas where they want to recover quicker, all right? So that's what they do in medicine. So in medicine, they've been doing it for a long time, okay? Not just to recover quickly, but also in cosmetics, which is a hot topic right now, okay? Growth factors are being used. This is something called a vampire facelift. I know that over here in Hollywood, they're doing a lot actually. A lot of my patients in Vancouver, they've heard or they've seen it being done, okay? So basically, what you do is that you get a little thing called the derma roller here. Okay, it's got tiny little needles, hundreds of needles. Okay, and you roll your face with that. So what happens? You create micropuncture. I mean, I don't do it in my office, but that's what you do. And your face starts, bleeding slowly, like this. Okay, so you've got bleeding face. You take a bit of blood. Okay, you spin it. Okay, on a centrifuge, on a specialized centrifuge that we have. In fact, they're using the same centrifuge in dermatology, and but techniques a little different tubes and so on. And you apply it, and you rub it on your face. Okay, and all the growth factor absorbs, okay, to your skin quicker because you've created all these micropunctures. And what happens, you get that facial rejuvenation. You start looking younger, prettier, and just amazing. So this is a hot thing right now. Okay, I know they're doing Botox and collagen. But this is your own, coming from your body. You're not mixing it with anything. 100% from your own body. Okay? So I know in Asia, they're doing a lot of that as well. Okay. You can actually inject it. with a 29 gauge small needle, you can inject it to your face. I've got a video on that later on, right? So it's being used in medicine, okay? So let me just walk you through some of the techniques for those who are not familiar with growth factors. So the first one was platelet-rich plasma, PRP, okay? And again, this is an old technique. Dr. Morris came up with that, okay? I don't use it again because there's too many steps, okay? And also you have to use some thrombin, okay, from cow bovine source, cow thrombin to it. And so the steps is very involved and it doesn't work very well, right? Now, and after that, something called PRGF, okay, platelet-rich growth factor. Dr. Anita from Spain came up with that idea, okay. It wasn't really useful in dentistry. Again, too many steps involved, right? And then Dr. Chopin from France, okay, he's a medical doctor, he's not a dentist, came up with the technique of PRF. This is probably what's being taught the most right now, yes? If you go to the lectures, everyone talks about PRF, right? And then Dr. Sacco from Italy, he came up with the term of a concentrated growth factor. Okay, so this is sort of the latest technique. Okay, there is some similarity between PRF and CGF, but it's different. It's a different unit, different machine. Studies have shown that CGF, there's more growth factors, okay, than PRF. And also, I don't like talking about PRF because they came up with what IPRF, LPRF, APRF. They're going through the alphabet. It changes every year, and you have to get a new machine. You have to get the tubes from them. There's a lot of politics behind it, and you don't need to know. But basically, Dr. Chopin, separated from the guys from down in Florida, and they got their own thing. They got their own patent, So, like, why so many techniques, right? I don't like that. I want to be able to just buy the unit and stick with a technique, and then so that I don't have to buy a different centrifuge, right? And also, they're telling you that if you want to use some of the techniques, you have to buy all the tubes from him. I don't like that either. Okay, I like to be able to get the test tubes and all the equipment from any supplier that I like, right? So here's the difference, okay? CGF, okay, is made with a Medifuge from Silfraden, which is from Italy, okay? PRF, this is typically what a box looks like, PRF. With the PRF machine, you have to control the RPM and the time and all that, okay? With this one here, it's very simple. It's specifically made for CGF, okay? So you put the blood in there, close it up, and you hit start, and that's it. It does everything for you. You don't have to worry about, looking at the RPM and the settings and all that, okay? So the other difference is that the Medifuge has UV sterilization. Okay, you can do that, okay? And you can use just regular tubes. Regular tubes from BD, from any other company, okay? You don't have to buy it specifically from France or from Florida. You can buy it from any supplier, right? I find that, I have both machines, right? I find that the membranes are thicker, okay? It has to do with the RPM because there's a variable RPM here. With this one, typically, depending who you talk to, they're saying, okay, spin it at 27 revolutions per minute for 12 minutes or 13 minutes. Some people are saying, oh, it's at 3200 RPM. Very confusing. I don't like that, okay? And what they've done in Italy, with Dr. Sacco, is that he has tested it actually at multiple variable RPM to see how much growth factors you can get. It's all preset. So the exact, the RPM, it varies actually. It goes at 2800, 3200, goes down, up and down. And because of the spinning involved in the RPM, they're extracting more growth factors from the blood, right? And Dr. Son from Korea has mentioned that that there's better regenerative capacity, okay, with CGF than the PRF. So here's the CGF here. So how do I use it? How can we use it? Right? So we're going to show you how to make it, but also how do I use it? That's the biggest thing. You can make it, but you don't know what to do with it. Okay? So I'll show you. I use an extraction socket. I think oral surgeons should be doing it all the time, especially if you're doing it in the third molar areas to prevent dry sockets. We use it for flap management. It works really well, okay? Especially when you're doing vertical incisions. If you have a membrane which you can slide underneath the vertical incision, you'll see, I'll show you the slide later, that it just heals very well. For those that know, when you do a vertical incision, it heals very slowly, isn't it? And patients have a lot of pain in that area. But by putting a CGF membrane underneath it, it just heals a lot quicker. It's perfect for open wounds. Areas that are slow, opening up too much, putting a CGF membrane works really well. I do grafting procedures every day, right, soft tissue. And if I'm doing it, if I'm taking tissue from the palate, I'll always put a CGF membrane. It just allows you to heal better, quicker, and patients obviously have less pain. Can we turn the AC a little bit? Is that okay? Getting warm in here. And also I'll show you how we can control, okay, uncontrolled bleeding sites. Sinus lift works very well as well, okay? Also, if you want to repair, okay, perforation of the sinus, it works really well too. I'll show you how to do that later on. Okay. Obviously, I use it all the time for soft tissue grafting. Okay. And patients that are medically compromised. What about patients that are diabetic, smokers? Okay. They don't heal very well, correct? They're very slow. They're more prone to infection during the healing process. Using CGF, it just allows them to heal quicker, get up and running as well, quicker. And what about patients on anticoagulants? Don't they bleed a lot easier, right? Adding growth factor in there, it'll prevent the bleeding happening for too long. Okay, it works very well. And this is sort of, for me, it's one of the biggest advantage of using CGF. It improves the handling of the graft material. That's the biggest thing. You just, I love doing bone graft now. Before, when I was using, a Gore-Tex membrane, doing block graft, it was just a lot of work. I mean, and the patients, too much complication after. But now, using CGF and mixing with the bone, it just makes it very, very simple. Okay. So what can you do? So you draw the blood. Okay, you get two things out of it. Okay, by spinning in the centrifuge, you get a membrane. Okay, which looks like this. So I'll show you how to use a membrane in clinical application. Also, you get something called autologous fibrin glue. Okay. So what happens is that instead of getting a membrane by using a different test tube, okay, you can get a liquid form like a glue, and you mix that with your graft material, and it makes the bone firm, sticky, putty style. Okay. So you get two things. I'll show you how to do that a bit later as well. And I use it all the time. If I'm taking a connective tissue graft, don't want to just close it up. I want to make sure that area heals quicker. So what I do, I slide one of the membranes, okay, underneath it before I close my palatal area, and the bleeding is just, oh boy, it's just way better. I mean, there's no bleeding there. Okay. I use it for frigid grafting as well.
Are you leaving it exposed here?
Here, I leave it exposed.
Oh, okay.
Yeah. What about uncontrolled bleeding sites? Okay. This is a patient that had grafting done, okay, about 5 days ago, and it just kept bleeding. Okay. He was a weightlifter. He works out all the time. Yeah. So obviously, my instructions are: do not lift any weight for the first week after the surgical grafting procedure, and obviously, he's hooked on it, right? So he has to do push-ups, and even if he doesn't lift weight, and doing flexing and all that. And what happens? It increases your blood flow, right? Heart rate goes up, and that area will open up. Okay. So it kept bleeding. Okay. So you put it all night. This is how it came in the clinic. Okay. So what's happening here? The little bubble, the blood clot gets bigger, right? And then it pops by itself. All right. And then it's bleeding, and you'll put pressure with the gauze, and then you'll get a bit of clot, and eventually it'll just pop and it keeps bleeding. So that was very difficult to manage. How would you manage that if it's a patient? Just pressure? That's not enough.
Laser.
Laser? Do you think that works with laser?
Yeah, you can use some to get rid of the stuff and cauterize it with the laser.
Cauterize it?
Yeah, use the laser. Did you have an implant? You don't have an implant, right? So.
I wouldn't use a laser. Good luck trying that. I have a laser. Cauterizing
Do you have
it when it's constantly
Do
bleeding.
you have an NDI or do you have depends on the laser you have.
It's too big. Yeah, you have a small opening, yes, you can do that. You can cauterize and stop the bleeding, but the wound here is too big. Okay, I mean, you cannot cauterize that. The moment you open this up, okay, it's just gonna keep bleeding. And we put laser in there, it doesn't do anything. It's too much. The area is too large. Okay, so what we did is I drew the patient's blood. Okay, and we got CGF membrane. Okay, there's a lot of platelets in there, growth factors. Okay, what I did is I intentionally popped it, okay, so I can get access underneath it, and we slide one of the CGF membranes underneath the flap. Okay, and what I do is I put pressure for about 10 minutes. Okay, that's what happens. About 10 minutes after, bleeding completely stops. Right, and then this is about a week later. It just heals a lot quicker. And trying to suture that, I mean, it's very difficult. Obviously, in the palp there, you cannot get primary closure if the tissue does not move. So this is something that you can do with CGF.
So did you not suture at all, or did you suture?
I didn't suture anything here.
Is that the membrane that we're seeing there, or what is
The
that?
membrane is underneath it.
Okay.
Okay, and you just put pressure in there, and it's clotting already here. And with these type of patients, if they're laying down, right, you can sit them up, okay, before you send them home. Sit them up, right, and have them sitting in the chair for at least 10-15 minutes, because the gravity sometimes will, pull the blood and open it up again. Okay. What about sinus perforation? For those who are doing sinus lifts, as you know, you're reflecting the membrane, and all of a sudden, boom, you have a little hole. Ooh, how do you manage that? Typically, they're telling you to put a collagen membrane in there. What else? Suture maybe. Have you tried suturing Schneiderian membrane? I tried it, and what happens? It gets bigger, right? Tears. The hole gets bigger and bigger. And what happens when you put a collagen membrane? So you have a little tiny hole, let's say, in the sinus. Do I have it? No. Let's say you're doing a lateral window sinus approach, okay? And you get a little tiny perforation in the sinus membrane, the Schneiderian membrane. How would you repair that? So we know suturing doesn't work. What's the other option? Putting a collagen membrane like a Band-Aid, like a patch? You could do that. But what happens with the collagen membrane? My concern is, what if it gets sucked up into the sinus? It's inside the sinus, right? With that collagen membrane, how long does it take to resorb or turn over? How long does it take? 4 months? 6 months? Right? And that membrane is sitting in there, okay, for 6 months while it's slowly resorbing. Do you think that thank you. Do you think that membrane is going to get infected? Yes. Very, very high chance of that membrane getting infected. So I don't like to put something that's very slow resorbing, okay, especially collagen membrane, to repair the perforation, because you can get sucked up into that little hole. Right? What I like to use CGF membrane. Okay? And that's what I use to repair that. Also, I use it to hydrate the implant. Okay? I don't do it all the time, but I do it for compromised sites and patients. Okay? Now, let's talk about improving handling of the graft material. Okay? So when you open it, the graft material comes in a container like this, dry. Okay? So I put a little bit of saline, correct? And you put it to the area, and it just gets everywhere, right? Underneath the flap, right? It gets to your instrument. You use a lot of it. Okay? So I stopped doing that because it's not fun, right? Try to scoop it up with a little, metal instrument and try to, bring it over. You lose a lot of it. It gets washed away underneath the tongue, the flap, and the bone a lot of times doesn't stay there, correct? Let's say if you're doing a lateral ridge augmentation, you just put a bit of hydrated bone in there, it doesn't stay, correct? You open it up, a lot of times it's just gone. Okay? So how can we make that from particulate to something like this, like a putty style, where you can pick it up, okay, with the tissue pliers? And that, it's got so much, it's very firm actually, okay? So it'll hold shape, it'll maintain the volume, which is the nice thing about this, okay? This is called the putty or sticky bone, whatever you're gonna call it. You can make it to different form as well, right? Different shape. which is a nice thing. So depending on the size of the defect, okay, you can make it round, flat, you can stretch it out. It's like a putty, Play-Doh, okay? I use it also in for GTR procedures around periodontal defects, okay? You can see what kind of growth we can expect. Okay, it works really well too. So while you spin the glove, okay, and you apply it to the area, but what's in it? Okay, so this is sort of the dry material, but what's inside of it? Okay, what's found in that little membrane or the glue that we get? Okay, there's a lot of cytokines, platelets. It's full of activated fibrin, right? And there's lots of leukocytes, growth factors, and antibodies. So we need all these things, to allow the area to heal quicker, right? So what are some of the growth factors that are in there? Okay, PDGF, transforming growth factor beta 1, beta 2, vascular and endothelial growth factors, and we need all these growth factors for healing. Okay, it's required, right? So Dr. Intini wrote an article, and we need all these things to allow for cells to come in, okay, to form matrix remodeling, okay, and get blood vessels into the area as well. So we get a fiber mesh over here with that, okay, with the CGF. It allows the blood vessels to form quicker, therefore you get better healing, okay. There's activation of cytokines, and also the local immune system gets improved, okay. And there's lots of growth factors coming from the growth from the membrane that we all make there, okay. So in turn allows the area to heal quicker, less pain, and so on. Now a couple studies here that shows the use of growth factors. So they're using PRP. So here we have a percentage of wound closing, okay, and time. So control sample without any growth factors and patients with growth factors. See how quickly they heal? Exponential. Okay. And what about pain reduction? Okay. Patient with pain with the growth factor, okay, and patients without it. See how quickly it reduces? Okay. Few comparison, okay. Professor Marks, 98, Dr. Raful, okay, and the Rossini, okay. They all found that there's a reduction of healing time by about 40 to 45% when you use growth factors, okay. What about pain? Okay, quite a bit as well too. So how's CGF made? Okay, you collect the blood. Okay, we're going to practice later on each other if you like. Okay, you collect the blood. Okay, we've got a very easy system with the vacuette tubes, right? And we centrifuge it, we spin it. Okay, and the machine will do the work for you. Okay, all you have to do is extract the blood from the patient. I find that when I'm giving this type of courses, the biggest obstacle of practitioners, being able to do this type of procedure is getting the blood. Okay, so I like to spend quite a bit of time. Okay? I mean, I had issues too when I was first doing phlebotomy. I could miss, I would miss veins all the time. Stick the patient once here. Oh, geez, let me go to the other one. Now what do? So I go to the hand. So I'll tell you, the first maybe 20 patients that I did initially, I was missing like veins left and right. So my success rate is probably about 50%. Okay, I mean, I sedate patients, so a lot of times they don't even know that I'm poking them. But still, you're wasting time and so on. So now, having done about many of these cases, right, my success is pretty good. But I still do miss, a few veins, here and there. Okay, but all I want to tell you is you got to keep trying. Okay, if you miss one, keep trying. Don't let that discourage you. Okay, from providing this type of service to a patient. Okay. If there's any courses in phlebotomy, definitely go and take it. All right, but it's not that bad. I mean, it's like, for me, it's almost like giving a block. I mean, when you're giving a block injection, right, mandibular block injections, I mean, I still miss a few here and there. We all do that, right? Sometimes we miss it. It's not very profound. It's the same thing. I mean, you get a technique after a while giving a block, correct? You know where you're going with that needle and how much you're giving. The same thing. You have to get a feel for it. Okay. So the Medifuge again. Okay. Some of the characteristics is that it's a single block rotor. Okay. And it's controlled acceleration, deceleration as well. It cools down. It controls the temperature by itself. Okay. And also it's got that UV sterilization ability as well, which is nice. So you spin it, and what happens? Okay, you get a bit of plasma at the top, okay, and you get a fibrin block component. So this is like a clot, all right. And at the bottom here, you have the red cells and the platelets. Okay, so what we use for our purposes is this portion right here. We don't use the red part, so you can discard that. Okay. So let's spend a bit of time learning how to obtain blood. Okay. So easiest way area is to get it from the antecubital fossa. Okay. It's less painful than going to the hand and the other areas. Okay. And the veins are fairly thick. Okay. They're quite prominent. Right. So you have to practice getting it from here. Okay. Yeah. It's not that bad actually. Okay, you'd be surprised. I like to get it sometimes. I like to go to the middle one here. I sometimes go to the one on the side here, or you can go to the one in the anterior portion as well. Okay, so a lot of times you got three choices: 1, 2, and 3. Okay. Going down here, you know, they do get a little bit thin, so I don't like going down there, and it's a little bit more uncomfortable for the patients. Okay. If you're really good at, you know, phlebotomy, I mean, I've seen some of the guys going to the hand, but I think it's very painful as well too, from what I hear. I haven't had it done in my hand, but I'm sure it's very painful, right? You do have to find a fairly thick vein though. Okay, yeah. Otherwise, if you go to the thin ones, a lot of times they'll collapse. You puncture and it'll collapse. Okay. If you're doing IV sedation, this is easy for you guys, correct? Yeah. How many of you are doing IV sedation here? Yeah, this is a piece of cake. Yeah. How about patients like that? How do you find the vein?
Send them home.
Send them home? This is, yes?
Vein light.
Vein light, yes. There's something called a vein light. You can get it. Do you want to talk about that a little bit?
Basically, it just projects, different color light through the tissue, and you just kind of push it down on the tissue, and you can clearly see the veins.
Yeah.
And it also stabilizes the vein. Like that's really
good.
helped me out a ton.
Good.
Because there are some people you can't, like this, where you just cannot see it unless you project that.
The light into it, right? It's
I
like
love it.
Yeah. And it's a very small machine. I mean, depending what kind of machine you get. I mean, the little one's about $400, $500, I think. You can go all the way up to $5,000, $6,000 machines, but you don't need to spend that much money. And they're portable too. They're battery operated, right? Portable. You just shine the light, and it'll show the vein clearly, which is kind of amazing. Vein light, yes.
Even on obese people?
Even yeah.
You're pushing it on the tissue, so it has like a little semicircle area where it projects light in between, and you're just squeezing down on it, and you can almost always see something. On obese people, it is harder because it's so deep. But without it, you have no chance. On those, you can't feel it, you can't see it.
Mm-hmm.
At least with this, it's projecting through, so you just spend your time looking for a vein that you can see,
Right.
whether it's in the hand or
It's like a transilluminator.
yeah, exactly.
Illuminator, yes.
Transilluminator.
Yeah.
Exactly.
With obese patients, doctor, you talked about obese patients. It's hard to get the vein. You don't see them actually. They're hiding way down deeper in the tissue.
You can't feel them either.
Yeah, so you gotta stick them a little deeper. And a lot of times I pray before I go in there. I'm gonna find it, but it's not that bad. It's amazing. You just get a feel. You do so many of them, you just get a feel for it. You just, okay, I think it's gonna be somewhere here, and you stick it, and boom, you're in. So you've got to practice it, okay? My recommendation is First of all, you don't look for it. For me, I don't like to look for it. You can visually you can see it a lot of times, but what I like to do is I like to feel for it, right? Yeah, because a lot of times depending on the skin complexity and the color, like this guy, I mean, you're not gonna see it. Good luck finding a vein. You have to kind of feel for it. So you're gonna feel that little bump, okay? But you gotta practice. Practice, practice, practice. That's the key. Practice on yourself, right? You have 2 arms, right? 1, 2. Practice on your wife, family members, your staff. That's what I did initially when I did it. I was trying to do it with my staff. My staff was, she's nice enough to let me practice on her. She didn't mind. And then you got your in-laws, right? Your lovely mother-in-law. She'll love it, right? Let me.
You tell her you're gonna make her younger.
Yeah, and you let her know that we typically go to the external karate for that. So let me see your neck, mom. So basically, it's very straightforward. You feel for the vein, okay? You put a tourniquet on just to make it nice and tight, constrict the blood vessels a little bit so that they'll pop out a little bit more. We use a vacuate container tube, which is very easy. So once you're in, it'll tell you whether you're in vein or not, okay? And straightforward, okay? So we use a vacuate with a butterfly. This is my recommendation. It'll make it easier for you guys. The butterfly system is very, very easy, okay? So you have the patient with a tourniquet, and you have them make a fist, firm fist. Usually you're gonna see that vein pop in the middle. Okay, that's perfect right there, okay? This is too small, too thin, okay? How about this patient? Oh, that's just lovely here, right there, okay? Small ones like that, no, those are no good, right? And there's different techniques with the phlebotomy. I'm not a phlebotomist. I've seen a lot of nurses, and so on, do it. I like to go in with a butterfly with a needle, and I like to hold it down with my hand. Some people put a tape over it. I don't like doing that. Sometimes the needles will slide out of the vein, and you're not in. Okay. So I like to keep my hand, hold it there, steady. Make sure that that the tip of the needle is inside the vein. Okay, that's very important. But whatever works for you guys. But my recommendation is not to put any tape over it, because by the time you're trying to get the tape and put it over it, the needle is going to slide out of the vein. And you don't have connection to the vein, you're not going to get blood. Right? So hold it down, or you're extracting the blood, okay?
When do you move the tourniquet? You keep the tourniquet on and
Yeah, question is, do you remove the tourniquet on, off? I just keep it in there.
Leave it up. Leave it up.
for a minute.
Leave it on, yeah. I'll just leave it on.
It doesn't bother,
No, it's not that tight. Patients can tolerate that. I mean, we extract the blood within a minute.
Yeah.
It doesn't take 10, 20 minutes to extract the blood. So, you just have the tourniquet on for about a minute and you're done.
Do you do IV sedation?
I don't have sedation.
Oh, okay.
So a little bit about manifuge, centrifuge. So how can we use it again? We use an extraction socket to cover the graft material, vertical incisions, palatal control bleeding, and the sinus perforations as well. So how is the membrane made? Okay. So you need to have something like this. Okay, it's a little kit that it presses the clot to make it into the membrane. So when you buy a centrifuge, they typically throw one of these guys in there. So what it is that there's a lid here, okay, and you place your CGF clotting here, okay, and then you close the lid. And what happens is slowly make it into membrane. Okay, it's nice and thin, right? So that's what you get after you're spinning it. Okay, you get some membrane here, 1, 2, 3 membranes. Okay, we're going to flatten it now. The red portion, we're going to discard it. Okay, there's different things. I mean, some people like to just pick it with a tissue plier from the test tube. I just throw the whole thing in there. Easy. Just open it up, throw the whole thing, and remove the red portion. Okay, and I just flatten it. Easy, saves a lot of time. And also, we have growth factors that comes in a liquid format, right? The autologous fibrine glue, and we'll mix it with the graft material. Having these 2 items, I can do pretty much anything in implant dentistry. I can do socket grafting, I can do lateral ridge augmentation, I can do sinus lift, whatever you like, right? So we spread them apart a little bit, and then we flatten it, okay? So
you use a different tube for the bone.
Yes, we're going to talk about that. Yeah, we use different test tube. Okay, same machine, different test tube, and it's all spun at the same time. You don't do it separately, okay? Each test tube will yield one clap, okay? Keep that in mind. So here, for example, I had 1, 2, 3, 4, 5. 5 tubes, okay? The maximum number of tubes you can put into the machine is 8. And also, it has to be also in even numbers of tubes. You cannot just put one in there and spin it. You know why? Yeah, it has to be balanced. So what happens? Let's say you just want to draw one vial of blood from the patient.
You put an empty one there.
You put an empty one with a bit of water in there, correct?
Yes, sir.
Yeah, exactly. And then you spin it. Okay. So after flattening it, this is what you get typically, this type of membrane. And the membranes are big. I mean, here's my Explorer. Okay. I mean, this is at least 30, 40 millimeter. Okay. And it's fairly thin and it's stretchable. You can stretch it. Yes?
How many cc's do you typically draw from a patient? Is there like a maximum amount that you
Yeah, it'll stop by itself actually with the vacuette
Right.
test tubes. Because there's pressure in there, you'll get about 8 to 9 mil at the most per tube.
Is there a maximum amount you could actually, I mean,
Get
how
from the
many
patient?
Right, from each patient.
Well, 8 tubes, 9 times 8 is 72 mils. That's the maximum. I'm sure you can get more, but you don't need to get more than that. Yeah. Typically, you just have to get about 2 or 3 tubes for most procedures. That's all you need to do. So you're taking out about 24 mils of blood. So very little, very little. Okay.
Do you lose a lot of that fiber, the growth factors when you flatten it?
Yeah. Yes. So the question is, okay, once you take it out from the tubes, it's a clot, right? And you flatten it. What happens? All the liquid drains down here to the bottom of the tray. So you're losing quite a bit of growth factors. You can actually get a syringe, okay? Just suck it up and then inject it actually to the areas. Okay. This is it's got some growth factors, mostly fibrin though, mostly fibrin. Okay. And then we make a sticky bone like this. I mean, this is just the beauty of the whole procedure. The sticky bone, I love it. Okay. They call it sticky bone because Dr. Son from Korea, he's sort of the original guy that came up with this technique. So his English is not very good, so he said, well, we got to term it something, so let's call it sticky bone. It sounds kind of cheap when you call it sticky. So whatever you call it, I like to call it putty bone. Some people call it sticky bone, the same thing. Okay.
What's the working time? How long you can just leave it outside?
The working time for both here, I get that question a lot. I mean,
I
but
think it's 3 hours.
you can leave it forever. Yeah.
But
But
they
I
said
mean,
you have to use it within 3 hours, so it's left. And that's what I'm
not really. You can leave it for longer than that. It doesn't affect. I mean, it'll dry up a little bit, right? But I mean, your surgery should be done in about 2 hours, right? If you're doing anything longer than maybe 3 hours, maybe. But if you're keeping a patient for 4 or 5 hours, you're doing something wrong there. Okay. But you can leave it in the countertop, for 2 or 3 hours, no problem. Okay. The only thing about membrane is that I'll close the lid on top of it just to make sure it doesn't dry. Yeah. Good. So this is something that you should still pay attention here. So how do I make the membrane into bone? Okay, by spinning at the same time. The difference is in the test tube or the blood sample tube. Okay, the one that comes in a red cap. Okay, we'll show you later. There's a silica coating inside of it, right? And the white one does not have any coating. It's just clear glass. Okay, doesn't have any coating. Remember that. And we use the one with the white cap to use the sticky bone to make it glue. Okay. But typically, you just need to get one white cap test tube for each procedure. Okay. And then, depending how many membranes you want to get, okay, you can get 1 or 2, 3 red cap test tubes. Is that making sense? So this is the difference. I get that question all the time. So what's the difference, Dr. Jane? Why one makes membrane and the other one just makes it into liquid? It's a silica coating. Okay, so remember that red has a silica coating in it. So with the red cap, you get 3 layers. Remember that? You get the bottom, red blood cells. The middle, you get the clot. Okay, and on top you get a tiny bit of plasma, which is a bit of liquid. Okay, and then we make it into a membrane with a red. Red is for membrane, remember that. Okay, white is for glue. Okay, with the white you only get 2 layers. Top, the clear liquid, and the bottom, the red blood cells. That's all you get. You don't get 3 layers. I know some of you have listened to my lecture a couple times already. There's a lot of information to digest, right? Okay, so if you're first time listening to this topic, it may be a little too much initially. My advice is you have some articles in there which you can read and kind of make sense a little bit better, okay? But keep it simple though. Okay, red and white. Membrane and sticky bone, that's all we make. Yes?
You know, sometimes I'm getting different rates of when a bone becomes sticky, so I don't know what's causing it.
So the question is, your comment is that the stickiness of the bone is it's different, right? Is that what you're saying?
Sometimes it doesn't get sticky till like, let's say, 15 minutes later.
Mhm.
Sometimes I mix it 5 minutes later, it's sticky.
Yes.
So I don't know what there's a difference.
Sometimes it'll take 20 minutes to make it sticky, right? I mean, so there is a difference in terms of setting time, okay? But I'll show you a technique where you can make it in 2 or 3 minutes or under. Instead of waiting 15 minutes. See, for me, everything has to be quick, right? I mean, my surgeries are typically about, anywhere from 45 minutes to an hour or so, maybe an hour and a half. So I like to do everything quicker. Okay, so I'll show you a technique, but there is a bit of variability in terms of setting time with sticky bone, but if you're waiting 15, 20 minutes, that's just too long. I like to wait about a couple minutes and just get done with it, okay? So let me show you a quick video, just so you can get the whole concept of venipuncture and so on, because I think this is quite important here. So this video, we're showing you how to identify the vein, okay, how to obtain the blood, and make the membrane of the bone, okay? So here's a unit that I use in my office. Very straightforward. On and off button here, okay? So I'm looking for vein here. Typically, when you just see it, you can't really see it very well. Okay, so I like to palpate if I can see the vein. And it makes a difference also when you put a tourniquet on. It makes a lot of difference. Okay? And you have the patient squeeze and make a firm fist, and you see the vein pop in here, somewhere in the middle. Instead of going down there, I like to be in the middle here by the antecubital fossa. Okay? Once you find the vein, you want to clean the area with a wet alcohol pad. Okay? And you can tap on it a little bit too, okay, to kind of make it a little more visible in different ways. Okay? And if you can't see, I like to feel for it, okay? I'm going to run my finger side to side. Okay? And you feel a little bump. Okay, that's where the vein is. Okay? So not a lot of times is it visible. Okay? One shift. So this is an important step here, okay? Let's see. So here we're getting set up here, I'll show you. So I've identified my vein, okay? So it's right there. Okay. Now we're connecting our vacuette to the butterfly. Make sure it's nice and tight. Okay. That's the vacuette. Okay. There's a little rubber ring there. Do not remove that. Otherwise, it's not going to create suction. Okay. So here's a needle. When you go with the butterfly needle, the bevel has to be up towards the sky. Okay. Not bevel down. Bevel up. Okay. The way you hold the butterfly, hold it like that. Your index and thumb, the bevel has to be up. I'm showing it there. Okay. So So I know where the vein is, okay? I hold the vein down a lot of times because some of them, they like to move side to side. So I hold it down and then I go in. Once I'm in, I hold it down, okay? And you can see a tiny bit of blood here. See that? Then you're in. At that time, what you have to do is connect the tube, white or red, and because it's suction, okay, the vacuum that's in the container, it does everything for you. Okay? It's not going to fill all the way to the top. It's going to fill maybe there's a line there, okay? It's about 90% of the tube. And it'll slow down, okay? And once it's completely filled, you take it out, put the next one, and see how quickly that's done, right? And the blood should flow at this rate. If it's coming out very, very slow, then you're doing something wrong, okay? So it's taking, I don't know, maybe 10 seconds to get one tube, okay? So my hand, I like to hold it steady here. Because this is the most important thing here. So take out the tube, put a gauze over it, and slide it out. Okay, we'll put a little bit of Band-Aid on it, okay? So now we'll put it into the machine. Okay. And we'll close it. And we'll hit it. It takes about 12 minutes. Okay? And it gives you 3 warnings. Okay? It beeps about 3 minutes prior. And it beeps again 2 minutes prior. And then 1 minute prior opens up. So here's my kit, just getting it ready. You can see there's little holes there, okay? And then the liquid will drain through the hole. And the machine will open up by itself, actually, which is nice. It gives you a warning, it open up by itself. So while this is going here, I'm freezing my patient. Okay? So we open it up. So remember with the red, it's got silica coating on it. Okay? And you twist the cap, and remove it, and just dump the whole thing. Easier that way. Okay? Some people like to take that yellow cloth with tissue pliers, but I just dump the whole thing. You see there's some holes here, okay? So I'm just going to separate it with a spatula and slide that portion underneath it. Okay. A little bit of red is fine, that's not a problem, okay? My stuff is just making it nice and clean. You don't have to do that. And you want to put the lid over it. And the weight of the lid will actually slowly compress the membrane, draining all the liquid portion out of it. And it's ready. And here we're showing how stretchable that membrane is. Some people like to suture it. You can do that too. Okay. So it's a fibrin block network there, okay? And the size is fairly big. I mean, that's a 20 millimeter probe, so thickness, I don't know, it's about 13 or so, or width. So that's good enough for one socket grafting, okay? And the nice thing is that it doesn't have any memory, it just drapes over the ridge, any area you want to place it, okay? So I'm just stretching to show how durable it is, okay?
So you're just using the weight of the lid, you're not actually...
Yeah, we don't compress it, just the weight of the lid is enough, that's all you need. Yeah. It's heavy enough to slowly compress it. I'll show you another video of how to make the bone, okay? So we open up a particular bone, that's an allograft, okay? We'll talk about the particle size a bit later, that makes a bit of difference, okay? So we empty it into a container. I like to use bigger sized particles, makes the bone much stickier. Okay. So from the white cube, okay, so we have the autologous fiber glue, and for this part, you have to use a syringe. Okay, so you place it right around the junction, okay, and you extract as much as you can of the clear component. If you pick up a little bit of red, it's fine. It's not gonna make any huge difference. Okay. And then we inject the whole thing in there. Just dump the whole thing. Okay. See how it's liquid? But that will become into glue. Okay, it'll make the bone bind all together. And I just let it sit there. Okay, shake it a little bit. Now here's the key. I'm adding a little bit of blood from the red tube. That's not from the white tube. Okay? If you add the blood from the white tube, it's not going to make any difference. The reason I'm putting 2 drops of blood from the red tube is to make it set quicker. Because that way it'll set in about 2 or 3 minutes.
That's amazing.
Yeah. And then you pick up all the particles. Okay? So you're going to get a little bit of liquid down there, that's fine. You just throw that away. And here's a sticky bone. You pick it up with the tissue pliers. So here I've got a buccal defect and socket grafting to do. We place it right to the area. It's got a lot of memory actually. Okay. See, I don't lose any particles here because it's all sticky. Okay. See how the graft material just wants to go back here? It just maintains the shape very, very nicely. It's not a messy surgery anymore. It's a clean surgery. Maintains the volume of the graft in the buccal area. Okay.
Is that 2 cc of bone? A vial?
That around 2 cc. Very good. I don't have to place any titanium membrane. I don't have to do any titanium mesh, you know. And that's my draft. See, I just shape it, okay? And that the volume will maintain, okay? And you can make a nice and clean procedure here. So obviously you have to cover some membrane, right? Put a membrane on top of it, like collagen membrane, and close it up. You cannot just close it like that. You have to put some sort of barrier. So my preference is to use collagen membrane, so I don't have to remove it. Right? So we wait about 6 months, and then place our implant. So surgery is easy. You know, you save a lot of time. You don't waste a lot of bone either.
Don't you have the post-op on that?
You know what? I made the video. I don't have it. Yeah, I should. And I placed the implant. You know what? I mean, I have the X-ray and all that, but I didn't have every single step. But I've got. You're wondering how the bone looks like, right?
I think he showed us in the ICOI, you
Yeah.
showed us a post-op picture of opening it up, and it was just beautiful.
Yeah, it's coming up here.
Pretty.
Yeah.
Do you put a membrane over it, or you just?
Yeah, always put a membrane.
Okay.
You didn't decorticate that either, right? With the upper
Oh, uppers I typically don't. Mandible, all the time. Okay? Because the bone is very dense. Okay? But in the maxilla, the bone is fairly porous. So if you decork it in the buccal, it doesn't make any, it makes it better, it doesn't make it any worse. Okay? So if you want to keep it consistent, I would just decorticate. It doesn't hurt.
I'm sorry, did you say you did or did not put a membrane on that?
Here, I did.
And did you use the membrane from that you made, or
I'll put a collagen membrane. Yeah.
and did you stabilize that with something?
No, nothing. I just put a collagen membrane. That's it. I don't put any tack, nothing.
Can you get away with not putting a membrane with this material?
No, you have to put a membrane. You have to put some sort of barrier.
And can you use the membrane that you made?
Good question. So instead of using a collagen membrane, can we use our CGF membrane? The only thing about CGF membrane, it doesn't last very long. Okay, it gets resolved fairly quickly. So it lasts internally about 2 to 3 weeks at the most. So you need more than that, in terms of keeping the barrier intact. So my recommendation is to use a collagen membrane.
Are you using CGF over the collagen?
You could, if you wanted to. I do a lot of times. So my protocol, you don't have to do it that way, but I put bone, collagen membrane, okay, and you can close it up. But what I do is I put CGF membrane on top of the collagen membrane, and I close it up.
And are you putting any sutures through the collagen membrane? Or
I don't.
Just laying it down?
I just put it on top. That's it.
And just close the flap?
Yeah, the reason is, why are you tacking the membrane on that? in order to stabilize the graft, right? But here we don't have to. Just put it over it. You don't have to be perfect. Just put it over it, close it up.
And you soak the collagen membrane in
You can do that, or you can just you say,
In saline.
soak it in saline. It doesn't make any difference. Yeah. So here it is. Sometimes the bone will look a little red because I've added those, drops of blood. If you want to make it nice and clean like that color, you don't have to add, but we'll just have to take a little bit longer for it to set. Okay. So these are the advantages. We have so many periodontists in Vancouver coming on board with this technique. I lecture at our local small, we have about 42 periodontists in Vancouver. Very small, right? It's a big city, but there's only 42 of us, which is good for me. I mean, you get a lot of business and so on. But once I show them these cases, they're like blown away. It's like, oh, this is the best thing ever. The sticky bone, wow. I don't have to use anything, like no tack, nothing, no membrane, no Gore-Tex membrane, just so easy, right? The only obstacle that they have is that getting the blood. They're still having some difficulties. I told them, go take some classes. There are one-day, half-day course on venipuncture, phlebotomy. Just take it. It'll just make your life so much easier. If you don't want to, just hire a nurse. Nurses will come, actually. Phlebotomists, they'll come to the office too. Yeah, the ladies that work at the lab, that draw blood, you can talk to them actually. I'll pay you $50, and can you come and do a case for me? They'll do it for you. Yes, question.
Can you kind of based on your clinical experience, can you tell us kind of what limitations you have, like how much width can you gain, or can you gain any height?
Yes. Yes. Limitation with this. You can do pretty much anything you want. I'll show you some extreme cases where I had like very thin bone, and I was able to gain like 10 millimeters of thickness. Okay. Question of, okay, can we get some vertical height? Let me tell you, gaining vertical height with any grafting material is very difficult. Okay, the only time you can do it somewhat predictably is doing something called distraction osteogenesis, which is way too invasive for us. Okay, well, you can gain some vertical height, but it's not predictable. Okay, but I've got a case that I did gain quite a bit of vertical height on a case. I'll show you that. Okay. So autologous fiber glue. Okay, make sure the needle is staying right by the junction here. They say that the growth factor is the most right in the middle here. Okay. I can use it in periodontal defects, with the vertical defects. At the distal of the second molar, very difficult to get in there. Okay, instead of just putting particular bone, I make sticky bone. Okay, we make sticky bone. You make it into a long form, and we just slide it in down there. It just fills it perfect. Okay. If you don't want to use any type of human cadaver bone, let's say you have a patient that just denies everything. I don't want to have any animal or human bone. I just want my own bone. And you're not comfortable doing a block graft, then you should get something like this. It's called the ACM, okay, by Neobiotech. And you just this thing spins actually and takes out little chunks of bone, which is very nice. Okay, so it's nice to one of those to have in your office just in case. Okay, let's say you want to do a grafting procedure and you don't have any bone in your drawer. Okay, just have one of these. It connects to your implant handpiece, and it's just nice. You can get easily 0.25 or 0.5 cc.
What's the RPM used on, like
50.
50?
50 RPM
Oh, okay.
with
So
no
without
saline.
irrigation.
Yeah, it's very slow, so it doesn't burn the bone.
Yeah.
All you have to do is just place this little spiral thing on top of it, and just press the pedal at 50 RPM, and you just put it over the cortex, okay? And it'll slowly rotate, and it'll give you chunks of bone actually that you can use. So if you're doing an extraction and let's say you don't have any bone, I want to do some socket grafting, just get some bone from the posterior area, same area if you want to. That's an option, okay? Because I do get every once in a while patients for whatever reason, religious reasons, whatever, they don't want to have anything cadaver tissue or animal tissue. And then this is the only option you have. How you guys doing? Okay? Need a break? A few more slides. Let's take a break in a few minutes. So when you look at the allograft, this is what it looks like under the microscope. It's got little tiny holes. Okay, so what happens here? All the osteoclasts and osteoblasts go in there, and it starts eating away this bone, right? And forming its own bone. Okay, that's why you have to use allograft, not alloplast, synthetic bone, or bovine. Okay, it doesn't work very well. So according to Craig Nish, the amount of growth factors I talked about earlier in the allograft, human cadaver bone, animal bone, synthetic bone is almost negligible. There's nothing in there. It's negligible. Right? Even the bone grafting companies are telling you, oh yeah, there's some BMP in there. It's clinically, like you said, it's not significant. It doesn't make any difference. Okay? So when you think about bone graft, you have to think about a few things. You cannot just put bone in there and expect it to heal. Okay? You need some cells in the surrounding area. That's why we decorticate, right? We get some blood, some cells. Also, we need a space making. So with a sticky bone, you just make the space. It stays, it maintains the space, it doesn't collapse, right? And then we know signals, right? Growth factors. The sticky bone is full of growth factors already. Okay? Blood supply. These are things that we need for proper, ideal grafting material. Another slide here. What do we need in terms of being able to regenerate tissue? We need three things. Okay, this is a very important slide here. Okay, scaffold again, spacing, right? We need some matrix space. We need space to maintain bone, right? Correct. We need some cells from the surrounding area, yes, and then we need some signals. What does the signals do? They recruit cells, correct? Chemotaxis. It sends signal to the cells, so all that the osteoblasts and osteoclasts, they'll come to the surgical area and start laying down bone. We need three things here. So when you look at the sticky bone, okay, so we've got scaffold here. Sticky bone, it maintains the shape, the space, correct? We have growth factors in a concentrated format because of the fact that we're using CGF, right? And you've got cells coming from the surrounding area, from the patient's body. So when things are accelerated, right, it just heals quicker. It just makes sense. What grafting companies are doing out there is that they know that we need more growth factors in the violet bone. So companies like OsteoHealth, they sell a lot of membrane and bone. What they start advertising is that, okay, we're going to have some bone graft material with the growth factors in it. All right, whose growth factor is this? Someone else, human. Would you want to have your own growth factor or someone else's? Okay, and it's a dry format, right? So there's not much in there. So this is called the GEM21, growth factor enhanced bone matrix. It's expensive. It's not cheap. Very expensive. And they were initially targeting periodontists. So they're telling us to use it in periodontal defects and so on. Number one was too expensive. It didn't work very well. So I don't know who's using out there, but that's what they're trying to do. Okay. What about a company like Medtronic? A huge medical company. They make pacemakers. They make brain stimulators and so on. They also make grafting material, but this is something called infused bone graft. Dr. Steve Wallace, he was lecturing on that back in late 2000 and so on. Okay. Basically, what it is, it's a sponge, okay, collagen sponge, and they put recombinant human bone morphogenetic protein. So they're trying to put growth factor in there, okay, so to make it heal quicker. So FDA approved it actually as an alternative to autogenous bone for sinus augmentation, okay, and also for ridge augmentation as well. This is gone here. Too many lawsuits right now. They're using it in other procedures, and patients were getting breast cancers. They're going through huge medical legal lawsuits right now, and it's too expensive. Yeah, and also the issue with that is that when they're placing the sinus, they just get a huge amount of inflammation. patients were getting a lot of pain actually. So this is gone. But you see the trend though, right? The grafting material by itself is not good enough. The ones that come in a vial. They're trying to always improve it. So what better than using CAGF from the patient's own body, right? There's no side effects. It's predictable. It's cheap to obtain it, right? Okay, let's take a short break, okay? And then we'll resume.